All right, so I'm sure there are lots of people on this table that would like to discuss back and forth, and we'll get to that. But before we get to that, I know Scott has all the equations that are necessary to solve all the problems.
Kind of breaking the rules here, but I couldn't do it without some visuals. So I do want to talk. I am going to only take 10 minutes, what was allotted to us, but I want to talk a little bit about the health economics perspective as an independent, equal opportunity offender. So, I think Lee actually presaged my comments by saying that, I have been equally excited by what I've seen here in terms of the technologies, and I'm at an institution that's at the forefront of this. But it still, for me, falls back to fundamentals. This is a new technology in a line that I've seen many of over the last 15 or 20 years. And I still want to apply the same tools, the tools that have been around actually for probably 80 or 90 years in health economic analysis, which is focusing on incremental value. And I didn't want to put up an equation for that, but the bottom line is we look at the way we're currently treating people, and we look at the new immunotherapy options. And we look at what we want to know is what's the additional health gain for the additional cost. And the tool of the trade for health economists is the quality adjusted life year. I realize that it's controversial, but it certainly is used in pretty much every other Western country outside of the US. So I think it's less controversy outside of the US than here. There are some things I think we need to think about with immunotherapy. They are marching along on this nearly exponential cost growth curve, and they are adding tremendous burdens to payers who are already burdened with a lot of other expensive drugs. And frankly, the burden to patients, something we've been studying a lot of at our group. The financial toxicity issues are getting worse for patients. And I think it's getting to a point where the access issue that the advocacy groups have been fighting for is now being countered by financial devastation, and that's also becoming an issue. But I do want to talk about one technical point, which is, and I was glad that this was brought up, this whole issue of durable responses, or in lay terms, cures. And the question is whether the standard economic approach applies. And I'm going to argue here that we actually may need to update our tools a little bit to deal with what we're seeing with these therapies. And the issue is that, as far as I can tell, for immunotherapies, the patients seem to fall into two categories. One is that they respond and they have a durable response that goes on for years, or they don't respond. Unfortunately, the tools we use in health economics group those together and doesn't account for that heterogeneity. So it results in an incomplete evaluation of the therapy and potentially a biased estimate, at least the way we look at overall survival. So here's an example of the pivotal trial for ipilimumab, showing a definite tail where patients have a durable response. The way economists would do this is using a parametric model, a Weibull curve, to sort of map the two. Problem is that it doesn't really account for that tail. So we're developing some new models that we call mixture or cure models that combine the issue of the patients who have durable responses, looking at the probability of those responses, and then mapping based on that response the longer survival for those who do versus those who don't. It's a fairly simple equation, as you see here. If you do that, again, going back to this early IPI pivotal study, you can see that a mixture cure model really fits the data much better, looking at the red and black extended curves versus the standard Weibull model, which is what economists would typically use. And that would probably include groups like NICE and the Australia Pharmacy Benefits Committee. So this is the interesting thing, I think, to me about these products, is that if you do respond and have a durable response, at least using this model, you can map not just months, but years, maybe decades of extra survival for that minority of patients who have the response. For those who do not, it actually doesn't look much better than the comparator drug. We're talking about weeks or maybe months at best for those who are not really cured. But if there is a cure fraction, as you can see down here for the IPI group, which is substantially higher, then I think accounting for with this mixture model improves things. Now, I'm an economist, and you do have to put costs into this equation too. So this model has to account for the fact that people live longer, they're going to cost more over their lifetime, but that's okay because they're getting additional survival and quality of life. So that has to be accounted for here, and in this model you can see that we map out the costs and the quality adjusted life year. But instead of lumping the entire population together, we've split them into those who've had the durable response and those who have not had the durable response. Bottom line is that using this model can substantially affect the incremental cost effectiveness evaluation. In this case, for IPI and advanced melanoma, the incremental cost effectiveness ratio goes from really terrible to somewhat less terrible, but it is a substantial improvement. And I think as we further refine the patient populations and identify markers for response so that we don't have to give full courses of drugs for people who aren't going to benefit, it could be possible to push the ICER down into territory that might be considered reasonable value. But again, we have to consider the cost as well as the outcome. So in conclusion, I think we still got to go back to fundamentals. This is a new technology, but it's the same problem. From a population perspective, we need to look at incremental costs and incremental outcomes when evaluating these, just like we do for every other technology in medicine. I do think, though, that perhaps we need to tweak our economic models to consider a new approach that accounts for patients who may have durable responses. And I think this mixture cure model may be one of the approaches that we can use. But finally, I think we do need to consider these other effects, which is, for the insurance companies, a lot of these drugs are being applied for rare cancers. They're getting through the Orphan Drug Act. And that's fine. That's not going to hurt them individually. But, it's kind of death by 1,000 cuts if we expand this sequentially into every cancer that we deal with. And the burden is just not going to be supportable by the public insurers or the private insurers. And this issue of patients who are now facing more and more of the costs as insurers wrestle with the fact that they can't charge premiums that are 100% of people's wages, so they're going to start turning more and more of the cost over to patients. That means the insurance model is going to break down for patients as they face more and more of these costs. So these are issues that are beyond cost effectiveness, but they're being directly confronted by the pricing models that pharma is having for these products. And I think we have to step back from the hype a little bit. I like that hype curve we saw yesterday, and think about the societal impacts of these therapies from a cost as well as an outcome perspective. Thank you.